In this video, I will be covering key concepts for Module 1 to 3. We'll divide it into cellular injury, genetic disorders, immunity conditions, and some cardiovascular disease and complications. So let's go ahead and get started. I'm going to share my screen here. Okay. So the first thing that we have are classic signs of inflammation. So we start off, so with this particular question or things to remember is that swelling, redness, and heat. So if you have a patient that comes in and they, got hurt and they're experiencing these classic signs, so this would be inflammation, okay? So this is a way that, or the body's way of signaling that something is wrong in that particular site, okay? Right, so now autoimmune disorder. So let's talk about one condition. So SLE, or systemic lupus erythematosus. So this is what you often see is that butterfly or that redness rash across their cheek. So you're going to see that the stiffness, painful joints, high blood pressure, and that redness, as you can see in this image. Okay. For bacterial infections, so like bacterial meningitis, antibiotics are typically the first line of treatment. So this is because they're an effective way against these bacteria. So this will not be viral infections, okay? So bacterial meningitis, antibiotics would be good for bacterial meningitis. Muscle atrophy. So this often happens when patients are prolonged in bed rest. So you as a nurse, you want to make sure there's no more muscle wasting. So one of the biggest things is getting your patient up and practicing those range of motion exercises so you're able to keep them as active as possible. GERD. So moving on to GERD, so we have this is gastroesophageal reflux disease. So long-term acidic acid exposure in GERD can lead to cellular changes. So one of these, it's most commonly known as metaplasia. So this means basically that the cells are adapting to ongoing irritation that you'll see. Okay. All right, so dysplasia and cancer risk. So speaking of cellular changes, so let's go ahead and look at dysplasia. Dysplasia is when cells, they start to grow abnormally. So this can potentially lead to cancer. So this is common in patients with conditions of chronic ulcerative colitis, okay? So if you have a patient that has that, they come in to the to your clinic or to the hospital, they have chronic ulcerative colitis, you want to see if they have that dysplasia, okay? Then we have squamous metaplasia. So this happens with chronic exposure to toxins. So this would be like cigarette smoking. So you have a patient that they are then, they're smoking a lot, so their cells are adapting that. So adapting to that cigarette or those toxins. Genetic disorders. So Tay-Sachs, so this is a devastating disease. This is found in infants that leading to progressive neurological decline, such as blindness. It is usually confirmed with a test called karyotyping. So in class, we kind of spoke about this being a little bit like an X-ray of your chromosomes. So you see this, you can see all the abnormalities there, okay? Right. Then the diagnostic testing, Down syndrome, cardiac conditions. So cardiac issues are also key. So myocardial infarctions or heart attacks, they involve severe chest pain that doesn't go away with rest or nitroglycerin. So You might also see symptoms like shortness of breath, heavy sweating, in contrast of heart failure, which is a chronic condition, is where the heart gradually becomes less effective with pumping, okay? And then we'll talk about the chronic and acute here in a little bit. Okay, we have ventricular fibrillation. So this is a life-threatening cardiac dysrhythmia. So this is marked by rapid uncoordinating of the ventricles. Angina, so this would be that chest pain that is relieved by rest or nitroglycerin, okay? So if you have a patient comes in, they're able to, their chest pain is relieved by rest, you know that quickly, you know that's going to be angina. Right, and the differences between these two, so heart failure, myocardial infarction. So heart failure, again, that's more of a chronic, so it's that inability to pump effectively, and MI, that's acute. So think of something that's cute, it's only cute for a little bit of time. So then that would be kind of MI. Right. Now, we have left ventricular heart failure. So some of the symptoms would be the crackles in the lungs. So you immediately know, let's just say you're hearing or taking a deep breath and you hear that those crackles in the lungs, you know that it's going to be left ventricular heart failure. Right ventricular heart failure, so the classic signs would be that the jugular venous distension, so the backward effect. So this would include those astrocytes. So if you see, underline this part. So if you see that they do have the astrocytes, that would be right ventricular failure. Okay. Then we have cor pulmonale. So this is right side heart failure. So this is due to pulmonary issues as well. Okay. Then we have acute bronchitis. So these symptoms include persistent cough, that yellow sputum production, and they're usually treated with expectorants, okay? Pneumonia, so inflammation of the lungs. So these are commonly caused by bacteria, viruses, or fungi. The most common one is the Streptococcus pneumonia. So this is community acquired pneumonia. Emphysema. So these are characterized by the loss of that elastic recoil in the lungs and tissues. So if you have a patient that comes in, so all of these questions are going to be pretty much patient-centered, like we talked about in class. So if you have a patient comes in, they have that loss of that elastic recoil in their lungs, you know it's going to be emphysema. Pleural effusion, so this is caused by an increase of hydrostatic pressure in the pleural space. So this leads to all that fluid coming up, and then so you can see here all that water kind of squeezing in, so that will be pleural effusion. If a patient has absent breath sounds, so this might indicate that pleural effusion or that the pneumothorax, okay? Right. Now we have wound healing. So secondary intentions is when the wound edges aren't closed together. So this leads to slower healing and scarring. So wound dehiscence is more like when the wound layers are separated. So this can happen due to the closure and compromise, okay? So in here we have the different types of primary intentions, the secondary, and intentions. Wound adhesions, so the separation of those wound layers, okay? The stages of wound healing, so for this particular, the same thing. So you have hemostasis, you have inflammation, you can kind of see a visual here, proliferation phase, wound contraction, and then you have that final stage of that remodeling, so putting everything back together. Right, hypersensitivity reactions are another area that we need to be familiar with. So for instance, the IgE, you want to know, you have a patient, they come in with allergic reaction, you know that they are going to have the IgE present. So the immunoglobulin, so this particular immunoglobulin is responsible for the hypersensitivity, those reactions found in those allergic responses. The type 2 hypersensitivity, so this involves a cytotoxic reaction, so such as blood destruction, okay? And again, mast cells, they also play a big role in the pathophysiology of allergic reactions. So if you have a patient that has pre-existing allergies, seasonal allergies, or hay fever. Alrighty. So then we have anemia. So this is defined by a decrease of hemoglobin concentration. So this includes hypotension due to that low blood volume. So if you have a patient, they have anemia, one of the biggest things that they're at risk for would be that low blood pressure. Iron deficiency anemia. So this commonly presents with hair loss or that craving for ice. So you have a patient, they come in, they have a lot of they're chewing on ice and hair loss. So that would be pointing to that direction of iron deficiency anemia. Sickle cell anemia. So this, both parents must be carrier for this gene. So the child can inherit this condition. So again, the same thing, a parent comes in, but only one parent is a carrier. So would they be at risk for that sickle cell anemia? No, right? Because they have to be both parents, right? Prolonged bleeding. So this may occur due to the absence of the clotting factor. So the clotting, they're not working to clot. So there's going to be that prolonged bleeding. Varicosity. So this is defined abnormal dilation of the superficial veins. The deep vein thrombosis. So you have a patient, they're experiencing that DVT. What would be one of those risk factors? So the risk factors would include immobility or reduced mobility. So that Vigro's triad that we talked about. All right. Moving on to oncology. So chronic leukemia. So this is characterized by those B cells that fail to mature. So you have a patient that comes in and you run their labs, you see the B cells aren't maturing, so that would be chronic leukemia. Hodgkin's lymphoma, so this is in the presence of red Steinberg cells. The people that are most at risk would be males. They're higher at risk than females, especially if they have a history of the Epstein-Barr virus. Okay. Neoplasia, so this can result into cells that are failing to go apoptosis, so leading to abnormal growth. Then we have viral infection, so Epstein-Barr virus, so this is called by mono. So remember that we kind of talked about a little bit about this like back in I think we said 2007. I think that's what we decided in class that was the time that mono was such a big thing. So this is called by the infectious monoleucus. So this is often referred as mono. So it's spread through the saliva, and then it causes that Epstein-Barr virus. So MI, the same thing. MI will be the elevated cardiac troponin, and then so what it does, it damages that heart muscle. So you can see that area. Neurological disorders. So we have Huntington's disease. So this is characterized by chorea. So the involuntary movements of our body. So this is followed by behavioral changes and then cognitive decline. Okay. Inflammatory responses. So chemotaxis. So this refers to the movement of white blood cells in the site of an injury during inflammation. Okay. The phases of acute inflammation, so this would include those changes in vascular permeability, so allowing those immune cells to access that site. So they're making it permissible that they're able to come on in, right? Right, and then we have coronary or CABG, coronary artery bypass graft. So what this does, it creates a new route for that blood flow. So they're able to treat that angina pectoris and the MI. The genetic testing again, so conforming of those chromosome disorders would be Down syndrome. And yeah, so I think these are little bit more. So cystic fibrosis, again, so this would include the chest physiotherapy, the corticosteroids, and reduce inflammation. So this would, another thing that we could do for your patient would be that the airway clearance techniques and also the bronchodilators. And then the differences between prognosis, etiology, and disease. Prognosis would be an expected outcome of the disease, okay? Regardless of the disease, it's what would be one of the outcomes. Etiology, this would be the study of the cause of the particular disease, and the disease itself would be defined as a deviation of the normal state of an organ or the system, right? Alrighty, so that is a overview of pathophysiology. And if you have any questions, please do not hesitate to reach out.